So welcome everyone to this ICP oral session on medication in pregnancy. The session is entitled Psychotropics, Bitter Pills to Swallow in Pregnancy. And we have 5 interesting presentations that we are very much looking forward to listen to. So my name is Angela Lupatelli. I'm a researcher at the University of Oslo in Norway. And it's a pleasure today to moderate this session together with Deborah Layton. Maybe you want to introduce yourself, Deborah?
Yes. Hi, good afternoon, good evening. I'm Deborah Layton, Director of Epidemiology at Global Database Studies, IQVIA, and very, very delighted to be moderating this session. Thank you.
Yeah, just first of all, I would like to inform you about a couple of points that will be useful for the session. So all attendees are muted. And also when you have questions, they should be entered in a Q&A box in the Zoom menu. And you're free to enter the question at any time during the presentation. But we have decided to structure the answering in 2 slots. So we'll be taking all the questions related to anti-seizure medication in pregnancy at the end, after the second presentation. And then we will be taking all the remaining questions regarding psychotropics in pregnancy after the end of the last presentation. So please be aware that all the sessions are being recorded and they will be available after the meeting is over. And to the presenter, please try to stay within the given time for your talk. We will try to help you by Deborah will turn on camera when the 10 minutes have passed so that you know that you have to wrap up and go to the next talk. Yeah, so to you, Deborah.
Perfect. So without much ado, I'd like to invite Marta Bjork to present on her presentation on prenatal exposure to anti-seizure medication and risk of neurodevelopmental disorders from the scanned AED in Nordic nationwide cohort study. Thank you, Marta.
Thank you, Deborah, and thank you, Angela. Let's see if I can share my presentation. Yeah. So on behalf of the SCAN AD study and the NORPRESS study, I would like to present our project Prenatal Exposure to Anti-Seizure Medication and Neurodevelopmental Disorders, and a Nordic nationwide cohort study. I am a consultant neurologist at Haukeland University Hospital, an associate professor at University of Bergen, and the chair of Bergen Epilepsy Research Group. These are my disclosures. The funding for the current study came from Nordforsk, the Research Council of the Nordic countries, as well as the Norwegian Research Council. Clinicians are often walking a tight rope when treating women with epilepsy in pregnancy. They have to balance the risks for the mother with the risk for the child. Generalized tonic-clonic seizures can be harmful for both the mother and the baby in pregnancy. Mortality in women with epilepsy is 10 times increased in pregnancy compared to women without epilepsy, mostly due to sudden unexpected death in epilepsy, which is associated with poor seizure control. However, anti-seizure medications can be harmful for the child. Children exposed to valproate have a more than 10 10% of children exposed to valproate in pregnancy are born with congenital malformations. Prenatal exposure to valproate is also associated with neurodevelopmental disorders, such as autism spectrum disorders, where the risk is 3 to 5 times increased. However, valproate is the most effective drug in common epilepsy types among women of childbearing age, particularly idiopathic generalized epilepsies. And alternatives that are as effective but less harmful in pregnancy is deeply needed. However, pregnancy safety of newer drugs and duotherapy is uncertain. And duotherapy is a combination of 2 drugs, and the neurodevelopmental outcome of such combination is totally unknown. The Nordic countries have similar health and socioeconomic registries that cover all inhabitants. By combining these registries, we can get data on more than 5 million births. ScanID is a population-based cohort study using linked health and social registry data from Denmark, Finland, Iceland, Norway, and Sweden. The aim of the current study was to investigate risk of neurodevelopmental disorders after exposure to anti-seizure medication. These are our data sources. We linked the medical birth registries to the prescription registries and to the records of specialist healthcare in all 5 countries. And we also linked these files, these registries, to socioeconomic data from the national statistical institutions. We transferred all registry files and pooled them at the server of Statistics Denmark. And we harmonized the variables according to a common data model that was adapted from the common data model of the NordPress study that you will hear more about later. Our exposure period stretched from 90 days before last menstrual period until birth of the child. So we identified prescription fills of anti-seizure medications and defined monotherapy as use of one anti-seizure medication type only, and duotherapy as the use of 2 distinct anti-seizure medications and no other anti-seizure medications filled within the same trimester. Then we followed the child for a median follow-up time of 8 years and identified diagnosis of neurodevelopmental disorders, such as childhood autism, atypical autism, Asperger's, intellectual disability, other childhood pervasive or disintegrative disorders, and global developmental delay. We investigated autism spectrum disorders and intellectual disability separately, but also pooled all these diagnoses into one outcome. We then did Cox regression adjusted for maternal age, education, country of birth, parity, maternal somatic and psychiatric disorders, use of antidepressants and opioids, pre-pregnancy admittances, child gender, and year of birth. These are our results. I will first present risk of autism spectrum disorder and intellectual disability after prenatal exposure to anti-seizure medication in monotherapy compared to unexposed children. So we had, compared to a reference group of almost 4.5 million children, we had identified more than 3,000 children exposed to valproate, more than 800 to topiramate, 1,600 to oxcarbazepine, and so on. And we found that the risk of autism spectrum disorders were 2.9 in the valproate exposed children, 2.5 in topiramate, and with lower hazard ratio for oxcarbazepine and carbamazepine, and not significant increased risks for the other drugs. For intellectual disability, we found that the hazard ratio was 4.3 for valproate and 2.8 for topiramate, around 2 for oxcarbazepine, and also slightly increased for carbamazepine and clonazepam. So as women with epilepsy are rather different from women without epilepsy, we also used women with epilepsy that did not use anti-seizure medication in pregnancy as a control group. And when we did this, we found that the risk of neurodevelopmental disorders, the combined outcome, we did not have power to investigate the single outcome of autism spectrum disorders and intellectual disability. So we did this analysis only for the common outcome of neurodevelopmental disorders, and we found that the risk was increased for valproate, but not for lamotrigine, carbamazepine, oxcarbazepine, and clonazepam. For topiramate, it was almost significant. We then did a sensitivity analysis restricting the exposure period to last menstrual period until birth. So we excluded children that were only exposed in the preconception period. We found that for clonazepam, oxcarbazepine, carbamazepine, and lamotrigine, the risk did not increase. But for topiramate, the risk was increased to 2.2. I will now present association between exposure to anti-seizure medication in different dose categories, as well as drug combinations with the outcome being neurodevelopmental disorders compared to unexposed children. This is a forest plot with that show the hazard ratio for a low dose compared to and for the high dose for lamotrigine, oxcarbazepine, valproate, oxcarbazepine, and topiramate. And as you can see, for valproate, there seemed to be a clear dose association where higher dose is clearly has a higher risk, 5.6 hazard ratio for a dose of estimated to be more than 750 milligrams per day. Also, for topiramate, there seemed to be a higher risk with higher doses. But for lamotrigine, carbamazepine, and oxcarbazepine, there is no relationship between dose and risk. We defined the dose as the cumulative sum of all defined daily doses divided by number of pregnancy days, and defined a high dose as using more than 50% of the defined daily dose. This is a forest plot of neurodevelopmental disorders in all the monotherapy exposures and also the 5 most common duotherapy exposures. Lamotrigine plus in combination with levetiracetam is the most common duotherapy used, and we also the next is valproate and lamotrigine, lamotrigine and oxcarbazepine, lamotrigine and topiramate, and levetiracetam and carbamazepine. And as you can see here, for all of these last 4, the risk is rather high for neurodevelopmental disorders, but it's not increased for lamotrigine and levetiracetam. As you can see here, risk for the lower bound of the confidence interval for valproate covers all these last 4 combinations, and none of the other monotherapies except for topiramate. So in conclusion, exposure to valproate and topiramate were associated with autism spectrum disorders and intellectual disability, but we did not find any other certain associations for other anti-seizure medications. Prenatal exposure to all commonly used duotherapies apart from levetiracetam and lamotrigine were associated with neurodevelopmental disorders in children. Thank you for the attention. I want to thank all my collaborators, both from the SCAN-AED study and the NordPress study. This is a very large effort requiring a lot of work for very, very skilled people. So thanks to everyone.
Thank you very much, Marta. What we're going to do is hold off on questions right now, and we're going to invite Jacqueline Cohen to present. She's from the Norwegian Institute of Public Health, also looking at a study using valproate and the Nordic and US data. So over to you, Jacqueline, and then we'll have combined questions.
Okay, can you see and hear me now?
Yes.
Okay, great. So thank you for the opportunity to present this work on the comparative safety of anti-seizure medication polytherapy versus valproate and the risk of major congenital malformations on behalf of the INPRESS consortium. This project was also funded by Nordforsk and the Research Council of Norway, and we have no conflicts of interest related to the present study. So as you heard, the drug valproate should be avoided as much as possible in pregnancy due to the increased risk of major congenital malformations and adverse effects on neurodevelopment. And in 2018, the European Medicine Agency's Pharmacovigilance Risk Assessment Committee recommended new measures to avoid valproate exposure in pregnancy. And at the same time, recognized that for women with epilepsy, it may not be possible to stop this medication. And that's because it's considered the most effective drug for generalized epilepsies. So therefore, alternative treatment may require using a combination of other drugs. So the objectives of this study were to describe the first trimester use of anti-seizure medication combinations that are relevant alternatives to valproate, namely those that are used for generalized epilepsies, and to determine whether specific ASM combination therapies are associated with a lower risk of MCM compared with valproate monotherapy. This was a cohort study that was restricted to pregnant women with epilepsy. We used data from the national registers of Denmark, Finland, Iceland, Norway, and Sweden, as well as administrative healthcare data from the US, both the Medicaid analytic extract and IBM market scan, as well as data from New South Wales, Australia, which was collected for the MUM study. We had one protocol for the study, but it was adapted to the different data sources. So we identified epilepsy in Norway and Finland using the indication for drug reimbursement, which is uniquely available for these sources. For Denmark, Iceland, and Sweden, we use diagnoses from hospital or outpatient specialist care from the national patient registers from 365 days before pregnancies up to delivery. For the US, this was from diagnoses in inpatient or outpatient care from 90 days before pregnancy up to delivery. And in Australia, the diagnosis came from all available hospitalization history, including the delivery hospitalization. When we describe the first trimester use of ASM combinations of interest, the relevant alternatives to valproate that we consider were lamotrigine, levetiracetam, topiramate, and zonisamide. We looked at prescriptions filled during the first trimester of pregnancy for both of the drugs of interest, and this analysis was not restricted to duotherapy, so they may have used other ASMs. For our outcome, we identified major congenital malformations using ICD-9 or ICD-10 codes, depending on the data source. And this outcome was based on aligning with the CDC definition in the United States and the EuroCat definition for the other countries. And this means that we excluded minor malformations in accordance with these more standard definitions. The data sources were the Medical Birth Register, the National Patient Register, and the National Cause of Death Register for Denmark, Iceland, Norway, and Sweden. And Finland uniquely has a validated National Register of Congenital Malformations. From the US, the diagnosis came from inpatient and outpatient claims, and from Australia, hospital admission records for the child. So when comparing ASM combination therapies versus valproate with respect to our outcome, We excluded pregnancies with chromosomal anomalies, genetic syndromes, teratogenic infections, and exposure to other teratogenic medications, which are listed here. We compared the risk of MCM among pregnancies exposed to ASM duotherapy versus valproate monotherapy. So therefore, we excluded pregnancies that had prescriptions for other ASMs from 3 months before pregnancy to the end of the first trimester. And we looked at lamotrigine and levetiracetam versus valproate monotherapy and lamotrigine and topiramate versus valproate monotherapy in discussions with neurologists as well as based on sample size considerations, which you'll see. For the analysis, we pooled individual level data from Finland, Iceland, Norway, and Sweden. And in the presentation, these are referred to as the Nordic cohort. And then the data from Denmark, the 2 US databases in Australia were analyzed separately. We did a basic adjustment for maternal age, delivery year, and country for the pooled Nordic data. And then we fully adjusted for additional confounders, including parity, diabetes, recent hospitalization, other medication use, et cetera, by propensity score stratification weights. So we used weighted log binomial regression to estimate risk ratios in 95% confidence intervals, and then combined those estimates using fixed effect meta-analysis. So here we see the results for the descriptive part of the study. The first column shows the database, and at the bottom we have the total. So across all of the databases, we had a total of 7.3 million pregnancies. And from those, we restricted to those with epilepsy, which ranged from 0.4% in the Nordic countries up to 1.2% in the MAX data. And we had 49,105 pregnancies with epilepsy. When we looked into the first trimester use of combinations of interest, the most common combination was lamotrigine and levetiracetam, with 705 total exposures. And that ranged somewhat from 9 per 1,000 pregnancies in women with epilepsy in the MAX data up to 23 per 1,000 in Denmark. The next most common combination was lamotrigine and topiramate at 283, then levetiracetam and topiramate for a total of 198, and lamotrigine and zonisamide and levetiracetam and zonisamide each had less than 100 total exposures, with more of the exposures in the US data sources. Here we see the numbers for the outcome comparisons. When we restricted to duotherapy and made the additional exclusions, we had 515 total that were exposed to lamotrigine and levetiracetam duotherapy. And due to small numbers, we can't share the exact cell sizes for some of these, but there was in the Nordic data 2.4% had a major congenital malformation. And that compares with the valproate monotherapy group, where there were 1,937 total, and overall 8% had a major congenital malformation. So well above what we expect in the general population of 2 to 3%. Here I'm showing the fully adjusted relative risks, and we see that they ranged from 0.25 to 0.68 for lamotrigine and levetiracetam versus valproate, for an overall pooled of 0.40, with the confidence interval ranging from 0.22 to 0.72. So a lower risk of major congenital malformations. And here Australia was excluded because there were no exposed events. For lamotrigine and topiramate versus valproate monotherapy, we had 183 total exposed to duotherapy, and a much higher rate of malformations in the Nordic data of 12.1%, and the same reference group here of the valproate monotherapy. Here, the fully adjusted relative risks range from 1.07 to 1.8. The market scan data were excluded from this analysis for no exposed events, and an overall pooled relative risk of 1.28, with a confidence interval from 0.72 to 2.26. So to conclude, the relevant polytherapy alternatives to valproate are rarely used in the first trimester and thus difficult to study. So I think this study really shows how difficult it can be to study these drugs in pregnancy, because even with over 7 million pregnancies and almost 50,000 women with epilepsy, we still couldn't get a lot of conclusive results in terms of alternatives to valproate. However, lamotrigine and levetiracetam, which are considered two of the safest drugs used for epilepsy, used together in duotherapy in the first trimester, is associated with a lower risk of MCM compared to valproate monotherapy. So this is reassuring. However, whether this combination is as effective as valproate remains to be studied further. So I'd like to thank you for your attention and again acknowledge the funders and my collaborators in this work.
Thank you, Jacqueline, and thank you, Marta. I'm looking at the chat and the question Q&A, and I see nothing. But I wonder if I may ask a question, both of you actually. Both of the results point to topiramate having excess risk. What are your explanations for that? Obviously, it's a known teratogen. Is it used first line in pregnancy? Because Jacqueline, you suggested it was, one of the four that was a suitable alternative. What are your thoughts about topiramate here?
It's not used as a first line drug. For this epilepsy, we try to use, for idiopathic generalized epilepsies, we try to use lamotrigine and levetiracetam as first line drugs, definitely. For focal epilepsy, we use oxcarbazepine and carbamazepine for these women. So it's definitely like a third or fourth choice. There is for autism spectrum disorders or for neurodevelopmental disorders, there is a theory, not been proven, but a theory that this risk of neurodevelopmental disorders can be associated with low birth weight, because we know from other studies that topiramate is associated with low birth weight. Actually, topiramate also decreases the weight of the mother. So both for the mother and the child can be weight. It's a weight reducing agent. So possibly it should be investigated whether this sort of increased risk can be explained by the effect on weight.
But in addition to that, there have been signals for topiramate for many years, especially for oral clefts. So, yeah. And I think that that's a malformation that's recognized right away at birth. And so for these data sources where we don't have super long follow-up, for the US data, we have 90 days, and in the Nordic data, we have at least 1 year. So I think those, we definitely pick those up if it's an oral cleft, but there may be other malformations as well. So I think this is, this evidence is building a case that topiramate may not be necessarily a safer alternative to valproate if it was considered potentially in the past.
And I've just seen a comment in the Q&A from Lauren Partler, who says, what's next in this line of inquiry? Is this evidence strong enough to push for policy label changes? And I'm assuming, Lauren, you're talking about topiramate.
Yeah.
Not valproate.
I think for valproate, I don't think that these restrictions can be any stronger than they are. And for topiramate, I think the evidence points that it is almost as harmful as valproate. I think it's of concern that a lot of, for example, within migraine, a lot of women also use topiramate for migraine prophylaxis. And after the new drugs for migraine came, the prophylactic, the anti-CGRP antibodies came, and Botox was available for migraine in many countries. To get these new and effective drugs reimbursed, it's required that you go through a trial of topiramate. So a lot of women in childbearing age are sort of forced to go through these topiramate trials to get drugs reimbursed for migraine. It's a large number of women, and I think that they there probably should be restrictions that may make it easier for them to not have to go through this if they are planning pregnancies, for example.
Okay. Okay. Thank you so much, both of you. We'll have to stop there. We could talk much more, and I'll hand back to Angela, and we'll go on to the next 3 presentations. Thank you.
Yes. So our next presenter is Elizabeth Suarez. She's a researcher at the Brigham and Women's Hospital, Division of Pharmacoepidemiology and Pharmacoeconomics. And the title of her presentation is Antidepressants Used During Pregnancy and the Risk of Neurodevelopmental Disorder in Children. So please.
Great, thank you. Hopefully you can hear me okay, and I'll get right into it. So this was funded by the National Institute of Mental Health, and we have no other conflicts to disclose. And there have been several studies that have attempted to clarify whether antidepressant exposure in utero increases the risk of neurodevelopmental disorders in children. The primary focus of most of these studies has been on autism spectrum disorders and attention deficit hyperactivity disorders. And the results from multiple meta-analyses have suggested that there is a potential increased risk for these 2 outcomes with antidepressant exposure, but also that the relative increase in risk is likely less than a magnitude of 2. And when studies considered maternal psychiatric conditions, these risks were mostly attenuated. And that uncontrolled confounding by maternal conditions, genetics, and environment is a plausible explanation for the observed increases in risk that we have so far. So in general, this is still a pretty unclear picture. So to address this, we wanted to do a study that particularly looked at antidepressant exposure in pregnancy and the risk of these outcomes in children, while prioritizing controlling for confounding by indication through careful selection of covariates and inclusion of sensitivity analyses to further adjust for unmeasured confounding. We also wanted to look at individual antidepressant classes and drugs, and also explore the etiologically relevant gestational window for exposure. So we did this using 2 data sources, 2 claims data sources. First is a publicly insured mother-child linked cohort from the Medicaid Analytic Extract. I'll call that the MAX data. And then we also have a privately insured mother-child linked cohort from the IBM Health MarketScan Research Database, which I'll refer to just as MarketScan. And so mothers were required to be enrolled generally from 90 days prior to the start of pregnancy through 30 days after delivery. And then we followed the linked children from birth to the end of their continuous enrollment till their diagnosis, the end of the study period, or death, whichever came first. So our exposure definition. So our main exposure looked at antidepressant exposure happening in the second half of pregnancy, because this is the period of synaptogenesis. And we compared this to our main reference group of having no antidepressant exposure throughout pregnancy and also in the 90 days prior to the start of pregnancy. We looked at this by class, so SSRIs, SNRIs, and TCAs, and then we also looked at the top 5 most commonly used drugs in our cohort, and these were predominantly SSRIs and also bupropion. In a sensitivity analysis, we also wanted to look at exposure in early pregnancy instead of late pregnancy, also compared to our unexposed reference group. And then we also did a sensitivity analysis where we use a discontinuer referent, because we expect women who used antidepressants prior to pregnancy, but not during pregnancy, to be somewhat more similar in their indications and characteristics. And I'll also note for the class and drug-specific results, this exposure to antidepressant prior to was the specific class or drug, and then no use of any antidepressant during the remainder of pregnancy. So we also looked at a long list of maternal covariates, about 65 or more covariates. And in particular, we looked at a list of potential antidepressant indications, including but not limited to depression, anxiety, bipolar disorder, and other mental health disorders, and any neurodevelopmental issues in the mothers. We also tried to define some proxies for mental health severity, and particularly by the number of psychiatric visits that the women had, their inpatient and emergency visits for mental health diagnoses, and their number of dispensings of other psychotropic medications, among other things. And then we also looked at lifestyle factors, comorbidities, other medication use, the adequacy of their prenatal care, demographics, and some county level socioeconomic status factors. So here are the outcomes we looked at. In addition to autism, spectrum disorder, and ADHD, we also looked at learning difficulty, speech or language disorder, intellectual disability, developmental coordination disorders, behavioral disorders, and then we have a composite outcome of any of these 7 specific neurodevelopmental disorders. And so we did complete a validation study to create all of these definitions and found in general that we had high positive predictive values for each of them. And so for our analyses, as a descriptive analysis, we estimated the cumulative incidence of each of these neurodevelopmental disorders in the children, stratified by exposure status and also by database. And then we calculated hazard ratios for each of these outcomes in our main analysis. And we did this in the MAX and market scan data separately, and then we pooled the results using fixed effects meta-analysis. And I'm just going to be showing you the pooled results today. And then the adjusted results, we adjusted for confounding using fine stratification on the propensity score. And then we have 3 main sensitivity analyses that targeted uncontrolled confounding. So first, we used a high dimensional propensity score approach to control for residual confounding remaining after we adjust for our predefined covariates. We have our discontinuer referent analysis, which I just described a few slides ago. And then we also did a sibling analysis, which is going to control for the shared environmental and genetic factors between siblings. So we're comparing exposed and unexposed siblings within the same family. So here are our exposure counts by database, and you can see in the second line of any antidepressant that we have very large numbers of women who were exposed to antidepressants in late pregnancy. Predominantly, this was SSRIs, but we do have fairly robust sample sizes to look at some of these individual drugs. And here are some cumulative incidence plots. So this first plot here is looking at any neurodevelopmental. So this is our plot of our composite of the 7 outcomes. And the blue line is our exposed in our publicly insured. We can see that it's really common for these kids to have diagnosed any neurodevelopmental by age 12, about 46%, much more common than the publicly insured children who are unexposed, and then lower even for the the privately insured children. And then we see these same trends in incidence between exposure status and database in autism and ADHD. So here I'm looking at our hazard ratio results, and I'm going to show you these for each outcome, and I'll walk you through how this figure is oriented. So our gray hazard ratio here is our unadjusted result. Then we have in this reddish color our adjusted result, and that's the hazard ratio that you'll see on top of each of these figures. And then we have our 3 sensitivity analyses, the HDPS, the discontinuer, and the sibling. So for autism, we see that the adjusted result is pretty consistent with no increase in risk. And this is consistent through our sensitivity analyses. We see for ADHD that our adjusted results suggest a hazard ratio of 1.2, but this is attenuated once we use our discontinuer and our sibling analysis. We see no association for learning difficulties, and we see a very small hazard ratio magnitude for developmental speech and language that also is attenuated in our sibling analysis. We see for developmental coordination disorder a hazard ratio of 1.15 that's then also discounted in our sibling analysis. Intellectual disability, we found no association. Behavioral disorders, and any neurodevelopmental, both small magnitude associations that are then also attenuated when we use a discontinuer and a sibling analysis. So this is looking at this by class and individual drug. So this red line here looks at our original result, and then blue, dark blue is the classes, light blue is the drugs. And to go through this quickly, you see that really no difference in our autism outcome across any of the drugs or classes. And the results for ADHD, maybe a slight increase in magnitude for some of these drugs, but it's very subtle. So generally, and also for our any NDD composite outcome, relatively consistent results by the drugs and classes. In this next slide now, I've used a discontinuer referent for each of these drugs and classes for these 3 outcomes. And for ADHD and any NDD, we see that shift towards the null for nearly all of these drugs and classes, as we saw in the main analysis. Unfortunately for ASD, the sample size does get quite a bit smaller. So these results are a little bit more variable and a little bit less precise. So additional sensitivity analyses that we did, as I mentioned before, we did explore exposure in early pregnancy instead of late pregnancy. And our results were very similar to the main results. And we did repeat the discontinuer and the sibling analysis for this exposure window also and suggested no association. We also required 2 dispensings for antidepressants in late pregnancy, just in case a single dispensing wasn't actually taken by the woman during her pregnancy, and we again see very similar results. So a strength of this analysis was that we had a very large population of both privately and publicly insured women and children that allowed us to look at individual drugs and also allowed us to do this sensitivity analysis with the siblings. We had validated outcome definitions with high PPVs, and we were also able to define an extensive list of covariates to capture these maternal antidepressant indications. We have to be careful not to overinterpret the sibling analyses because there's the possibility that the attenuation of results is due to exposure misclassification and the fact that we're estimating direct effects in this analysis. But in conclusion, while we did see that children exposed to antidepressants in utero had a higher incidence of neurodevelopmental disorders than children who were not exposed, our results do not suggest that antidepressant use in pregnancy is a major causal factor for these developmental disorders in children. And so the very large attenuation of unadjusted effects after adjustment that we see is evidence of this, as is the results of the sensitivity analyses that were designed specifically to address residual confounding. Our exposure misclassification analyses do not suggest that our results are due to misspecification of antidepressant exposure status, and our results were generally consistent across classes and drugs. And any remaining significant effects were quite small in magnitude, generally less than a 20% increase in risk, which could plausibly be explained by residual confounding. So I'd just like to acknowledge the team and our advisory committee, and thank you.
Thank you very much, Elizabeth. Very nice presentation. As we did in the prior slot, we will take now the 2 more presentations by Krista and Loreen, and then we will have the Q&A session at the end, since all 3 presentations are about psychotropics. So we can go to our next presenter, who is Krista Huybrecht. She's an epidemiologist at the Brigham and Women's Hospital, Division of Pharmacoepidemiology and Pharmacoeconomics, and also associate professor at Harvard Medical School. So she's presenting her latest research with title The Impact of In Utero Antipsychotic Drug Exposure on Congenital Malformation, an International Cohort Study. So the floor is yours.
Thank you, Angela. It's really my pleasure to present today on behalf of all the co-authors, which are all members of the International Pregnancy Safety Study Consortium, referred to as INPRESS. We have no conflicts of interest to declare related to this study, and the study was partially supported by research funds from NerdForce and the Research Council of Norway. So in terms of background, antipsychotic medication use during pregnancy has strongly increased over the last 2 decades. And then in particular, the use of atypical antipsychotics, as you can see on those 2 figures here. This despite the fact that there is limited information on the potential teratogenicity of these medications. So the objective of our study was to evaluate the risk of first trimester antipsychotic exposure with respect to congenital malformations, and we were specifically interested in evaluating individual drugs and specific malformations. As I alluded to in the beginning, so this is a collaboration of the INPRESS consortium. So we had access to data from both the US and the Nordic registries. So for the US, we had a little over 2 million pregnancies linked to their live-born infants. In the Nordic countries, we had a little over 4.5 million pregnancies linked to singleton live-born infants. And the contribution of each individual countries is shown here. So in general, we included live-born infants with no evidence of chromosomal abnormalities and no evidence of first trimester exposure to what are considered known teratogens. As I mentioned in the beginning, we were interested in evaluating individual drugs in addition to the drug classes. So we're looking at atypical antipsychotics and typical antipsychotics as a class, and then individual drugs. And women were considered exposed if they filled at least one prescription for the drug of interest during the first trimester. And you see the different exposures that we looked at listed here in order of their prevalence. So from most prevalent to least prevalent. The orange bars indicate the use in the US and the blue bars indicate the use in the Nordic countries. The typical antipsychotics are indicated in green font size. And as we can see, other than the classes themselves, the atypicals are the most frequently used in general, followed by the typical antipsychotics. In terms of the reference group, we considered women unexposed if there was no dispensing for any of the antipsychotics from 90 days before the start of pregnancy until the end of the first trimester. Then in terms of the outcomes, as I mentioned, we were interested in focusing on specific malformations, and then specifically malformations that had previously been suggested to be associated with antipsychotics. And we cast a relatively broad net. So this was based on either evidence from cohort studies or case control studies, or even individual case reports. And so in addition to the congenital malformations overall as a group, we considered 10 specific malformation types, which are listed here. In terms of the outcome defining algorithm, we allowed for slight differences between the US and the Nordic analyses. So in the US, we looked at the first 3 months after birth. In the Nordic countries, we evaluated the first year after birth. And then in terms of the algorithm itself, for the US, we considered either 2 diagnoses on different days, or a diagnosis in a procedure, or a diagnosis in infant death. In the Nordic countries, we required either 1 inpatient diagnosis or 2 outpatient diagnoses on different days. With respect to the potential confounding variables, again, we considered a very broad range of potential covariates, more than 65. I'm not going to go through each of them individually. They're here just listed for reference, but I wanted to briefly touch upon the different categories that we considered. So we looked at demographic characteristics, maternal medical conditions and obstetrical conditions, psychiatric conditions, obviously, maternal medication use other than the antipsychotics, healthcare utilization, such as number of distinct diagnoses, inpatient visits, outpatient visits, and so forth. And then we also adjusted for potential teratogens. So well-established known teratogens were excluded. Potential teratogens where the evidence is a little bit more mixed, we adjusted for in the analyses. And then in terms of the analysis themselves, so we started with describing the population and the exposed and the unexposed cohorts and estimating the unadjusted relative risks with their 95% confidence intervals. I won't describe that today in the interest of time. So what I really want to focus on is the adjusted analyses. And the adjustment was done at the level of the individual countries using country-specific propensity scores. And from this pool of 65 potential covariates that we defined, the selection of variables and the number of covariates selected was determined by the number of exposed patients in a given country. We excluded births in the non-overlapping areas of the propensity score, and then created an equally sized propensity score strata based on the distribution of the propensity score among the exposed. We required a minimum of 3 exposed per stratum and a maximum of 50 strata were considered. And then finally, we pooled our results across propensity score strata and across countries using a standardized morbidity ratio approach. We also conducted a whole range of sensitivity analysis to test the robustness of the findings. But again, in the interest of time, I won't be focusing on those today. So what I really wanted to focus on today is how to present and interpret results when you're looking at so many different exposure outcome associations simultaneously. And I just want to orient you to the table that I'm displaying here. So the rows are the different exposure groups. So these are the 18 different exposure groups listed in the same order that I've shown you before, from most prevalent to least prevalent. So from most information to least information. The columns represent the different outcomes we evaluated, and again, organized from most common, so any congenital malformation, which has a prevalence in the unexposed of about 35 per 1,000, to the least common, in this case, esophageal atresia, which has a prevalence among the unexposed of 0.17 per 1,000. In the cells themselves, we display the relative risks, the adjusted relative risks. So this is the estimate that is most consistent with the data. Then I want to talk a little bit about the shading. So the shading actually reflects the upper limit of the 95% confidence interval. So the darkest shade of gray indicates that the upper limit is greater than 10. The next shade of gray indicates that the upper limit is between 5 and 10. Next one between 2 and 5. And then the lightest shade of gray indicates that the upper limit of the 95% confidence interval is less than 2. Wherever you see a 0, that indicates that there were no exposed events, and therefore the relative risk is going to be 0. And then finally, the bolded numbers indicate that the relative risk itself is greater than 2. So how do we now interpret all of this information? So if we first focus on the lower part of the table, this is where we have the least information, either because the exposure is very uncommon and or because the outcome is uncommon. And what immediately becomes obvious that this is where we see all of these 0 cells. So in most of these instances, we have 0 exposed events. When we are able to estimate a relative risk, the relative risk tends to be high and the confidence interval tends to be wide, indicated by this dark shade of gray, because the upper limit is greater than 10. And these estimates are really driven either by just one exposed event or just very few exposed events. So moving on to sort of the second group of associations that is in the upper corner of the table, this is where we have most information. We're looking at the more common outcomes and the more common exposures. And what immediately becomes obvious there is that the relative risks really tend to center around 1. The confidence intervals tend to be much narrower. In almost all cases, we really can exclude a relative risk greater than 2 based on the upper limit of the 95% confidence interval. So that leaves us with this, the only potential exception is for olanzapine and oral clefs. So here the relative risk is 2.1 and the upper limit of the 95% confidence interval is 4.3. And that sort of leaves us then with that middle component where we have a medium amount of information. And this area is really much more challenging to interpret. Just looking at sort of these median shades of gray, it becomes immediately obvious that in most instances, we can't exclude a relative risk greater than 2 based on the upper limit of the confidence interval. There's also a lot more variability in the point estimates themselves. But again, the highest point estimates clearly sort of are closely aligned to that area of the table where we have the least information. So how did we interpret this amount of information? So based on the totality of the evidence, we concluded that there is no clear indication that antipsychotics are associated with an increased risk of malformations. Couple of points I wanted to highlight, a couple of challenges. So we are dealing with uncommon drugs and rare outcomes. And as I sort of illustrated in that lower side of the table, it's really important to keep in mind that one single exposed event will result in very large relative risks with wide confidence intervals. So this is really important to keep in mind when interpreting results in that part of the table. The other challenge is that with 18 exposures and 11 different outcomes, just looking at the main analysis alone, the base case analysis, we're dealing with 198 different comparisons. So we are going to have chance findings of an increased risk, even if there's no association. I haven't really focused on statistical significance because that's not really where our emphasis is in epidemiology. We really want to focus on estimation of magnitude and precision. But I did want to share that after adjustment for multiple testing, actually none of these associations reach statistical significance. Next point I wanted to make is that although we started from a large set of potential confounding variables, more than 65, looking at a specific exposure outcome association, sometimes there was limited confounding adjustment because the number of variables that could be adjusted for at the country level was really determined by the number of exposed in that given country. So there's definitely still potential for residual confounding. And then finally, although not something I've really touched upon a lot, but just wanted to share, there are some challenges that we're facing that are related to disclosure limitations. So for example, for the US data, the Medicaid data, we cannot disclose cell sizes less than 11. For Denmark and Finland, this is less than 5. So we can only, when we're looking at these uncommon exposures and uncommon outcomes, we can only share relative risks, not the number of outcomes, which would be informative. So to conclude, I hope to at least have shared some ideas on how we can present and interpret information in the context of multiple exposure outcome associations that are being evaluated. And I just wanted to end by, again, recognizing the various collaborators and their affiliations here. So thank you very much for listening. And then I think, according to the moderators, we'll just take the questions after the next presentation.
Yes, that's correct. Thank you so much, Krista. So now we can proceed to the last presenter. She's Loreen Straub, research specialist at the Women and Women's Hospital Division for Pharmacoepidemiology and Pharmacoeconomics. And the work she's presenting today is entitled The Impact of In Utero Antipsychotic Exposure on Neurodevelopmental Disorder. So please, Loreen, the floor is yours.
Thank you. Thank you for this introduction. So just a quick question. Can everybody hear me and also see my screen?
Yes.
Okay, wonderful. All right. You just heard the topic. So let me just quickly go to presenter mode. All right, so I will jump right in. So first of all, this research was funded by the National Institute of Mental Health, and the authors of this project have no conflicts of interest related to this project to disclose. So you already heard a lot of things about antipsychotics. And so I would just say this again, like especially here in the US, antipsychotic drugs are very commonly prescribed and are among the most commonly prescribed drug classes. And so their clinical use extends beyond just psychotic disorders and includes bipolar, major depressive, and anxiety disorders, all of which are very common among women of childbearing age. And so while there are some animal studies and also some evidence in humans suggesting that there might be adverse neurodevelopmental effects of these antipsychotics, the currently available data, specifically in humans, comes mainly from case reports and small case series, so the question still remains unresolved. And big challenges when assessing these associations are due to the fact that we need large patient cohorts with both long follow-up and also adequate confounding control. So therefore, large-scale epidemiologic studies are urgently needed. And the objective of this study was therefore to evaluate the impact of in utero antipsychotic exposure on the risk of long-term neurodevelopmental disorders using such large-scale databases. And since our study cohort is actually very similar to what Liz has already described before in her project, because we both worked on this together, I would just keep this very short. So we basically use the same data sources. We use the Medicaid Analytic Extract and the IBM MarketScan database, which includes information on both privately and publicly insured mothers linked to their live-born children. We use the exact same eligibility requirements that Liz had mentioned before. So I would just skip this in the interest of time. We looked at 2 different assessment periods for antipsychotic exposure. And so our primary period included the second half of pregnancy, which is considered the period of synaptogenesis. However, since there is still uncertainty about the etiologically relevant window, we also looked at the first half of pregnancy as a secondary assessment period. And we defined exposure based on the presence of at least 1 dispensing in the respective assessment period. In addition to looking at any antipsychotic exposure, we also looked at atypical and typical antipsychotic use, and also assessed exposure to the 5 most commonly antipsychotics, which were quetiapine, aripiprazole, olanzapine, risperidone, and haloperidol. The reference group included all women without any antipsychotic exposure from at least 90 days prior to pregnancy up to delivery. Our outcomes of neurodevelopmental disorders were identified using previously validated claims-based algorithms, which have been presented here last year, and which are basically the exact same outcomes that Liz had already described. So in addition to autism spectrum disorder and ADHD, we also considered 5 other individual developmental disorders. And as an 8th category, we also looked at the presence of any neurodevelopmental disorders. We considered a lot of different potential confounders and proxies for confounders. And just in the interest of time, I will not go into detail here. I just want to highlight that we really accounted for different treatment indications and lifestyle factors. We accounted for mental health related issues, as well as comorbidities and concomitant use of other drugs, demographic factors. And as far as it was possible, we also accounted for socioeconomic status measures. We started our analysis by, first of all, just looking at the covariate balance between exposed and unexposed. We then created cumulative incidence curves using Kaplan-Meier analyses stratified by exposure, and calculated the hazard ratio using Cox models. We did this both unadjusted and adjusted, for which we use propensity score overlap weights. And lastly, since we have 2 cohorts, we combined the results using fixed effects meta-analysis. We also conducted several sensitivity and exploratory analyses, and I will talk a little bit more about this later. So in terms of cohort characteristics, first of all, I just want to give you an idea of what our numbers actually look like. So in our publicly insured cohort, we have about 10,000 women who are exposed to antipsychotics in the second half of pregnancy. Most of them are exposed to atypical antipsychotics, and among these, most are exposed to quetiapine, as compared to more than 2 million unexposed women. The numbers in our privately insured cohort are considerably smaller, with about 1,200 women being exposed in the second half of pregnancy, as compared to 1.3 million unexposed women. When we now look at our covariates, we observe that women who use antipsychotics in pregnancy are more likely to be older and white. They have more comorbidities, are dispensed more commonly other drugs, and have, like, in general, less healthy lifestyle behaviors. And those patterns are actually observed for all our exposures that we looked at and both assessment periods. When we look at cumulative incidence, we basically see the same patterns for each outcome and each exposure, and also observe the same patterns in both cohorts. And that is that children who are exposed prenatally to antipsychotics have a higher cumulative incidence of having a developmental disorder as compared to those who are unexposed. And just to put this into some numbers, by the age of 8, about 1/3 among the publicly insured children with neuro exposure to antipsychotics have a diagnosis of neurodevelopmental disorders, as compared to 24% among the unexposed. And the incidence is smaller in the privately insured cohort. However, that difference between exposed and unexposed is still quite large. Now, what I'm showing you here on this slide gives you the pooled unadjusted hazard ratios separately for each of our outcomes of interest, looking at women with any antipsychotic exposure in the second half of pregnancy as compared to the unexposed. And what we see here in terms of hazard ratios is very consistent for what we also observe for the other exposure outcome contrasts and both assessment periods, and that is that the hazard ratios, the unadjusted hazard ratios, are typically around 2. Now, this changes drastically once we adjust for these covariates that I had described before. So after adjustment, the results do no longer suggest a substantially increased risk for all our exposure outcome associations. There's just one exception, and I'm going to talk about this now, and this is aripiprazole. So for aripiprazole, after adjustment, we still see increased risks for several outcomes. Of course, like taking sometimes large confidence intervals into account. And so, as I mentioned before, we conducted several sensitivity and exploratory analyses. We had several a priori specified analyses that we conducted for all our exposures. And in the interest of time, I will not go into detail here. I just want to highlight that the results we observed there were very consistent with those from the main analyses. And there's also no evidence for a potential association between days supply and the risk of developmental disorders. In addition to that, we conducted several post-hoc analyses just for aripiprazole, where we saw that increased risk for several outcomes. And even there, the results remain consistent with those from the main analysis, meaning that we still see those increased risks no matter what we do. However, there's no clear evidence for a dose-response relationship. So before I go to the conclusions, a few words about strengths and limitations. So one strength is definitely that we have these 2 large nationwide cohorts available with follow-up of the children up to 14 years of age. In addition to looking at any antipsychotic exposure, we were also able to evaluate the impact of individual antipsychotics in different assessment periods. And we also looked at specific developmental disorders using validated outcome definitions. And lastly, we feel that we really put careful attention to a broad range of potential confounding variables and also conducted extensive sensitivity analyses. Nevertheless, there are always limitations. So there might be residual confounding, for example, due to genetic predisposition. However, given that we see those null findings for most exposure outcome associations, it might be less of a concern here for aripiprazole. Similarly, there might be the potential for exposure mass classification. However, we conducted several sensitivity analyses, such as requiring at least 2 dispensings, and the results were very similar to our main findings. And lastly, what I want to really emphasize here is that aripiprazole is a little bit different than the other antipsychotics in the sense that aripiprazole is a dopamine partial agonist, whereas the others are antagonists. And so what this means is that aripiprazole can actually reduce prolactin, which can therefore lead to problems with breastfeeding. And so one hypothesis might be that the effect that we observe for aripiprazole might be potentially mediated through a reduction in breastfeeding. However, our data does unfortunately not provide enough information on breastfeeding, but we feel that this might be an important avenue to explore in future studies. In conclusion, our findings suggest that there is no increased risk for neurodevelopmental disorders with in utero exposure to most antipsychotics, and these findings held up across a broad range of sensitivity analyses. However, we feel that future investigation should really focus on that potential effect that we see for aripiprazole. Nevertheless, what I really just want to highlight here is that while our adjusted results are not suggestive of a causal effect for most antipsychotics, we still see that unadjusted 2-fold increase in risk for most developmental disorders among women with mental illness. And we feel that this really highlights how important it is to both early intervene and also support these women as well as their affected children. And with this, I would like to end this presentation and thank my co-authors, including our advisors, for all their great support. And I want to thank the audience for listening. And now I'm happy to answer any questions. Thank you very much.
Thank you so much. That was very good. And very really important work, all the three presentation from a clinical standpoint. I don't see any question in the Q&A box. So I might start. I have a general question to all three of you. Taking a bit, thinking about the workshop we had yesterday about the target trial. I don't know if you've been attending it, about perinatal. And looking at the presentation today, I was wondering, what are your thoughts of the target trial in this setting? Shall we start with women having a diagnosis at some point before and during pregnancy? And when is the treatment assignment given when we want to study specific timing of exposure in pregnancy? I think I would like to hear your thoughts on this.
We definitely could. I think, especially given the fact that we do have really large sample sizes here, try to create exposure definitions that are more trying to target timing of use and potentially looking at women who are initiating in pregnancy or women specifically who initiated prior to and continued. I think that's potentially possible here. And it could also, one thing I think is a little bit difficult with the kind of wider exposure window, like the late pregnancy exposure window, is being able to properly capture those indication variables in relation to when the medication was actually maybe started or continued, or how her mental health care is going throughout pregnancy. So the target trial framework of really looking at maybe women who initiated versus didn't among women who have an indication might clarify that.
Sorry, Elizabeth, I think there is some sound, background sound. I don't know if it's, can you try to speak? Yeah.
Yeah, can you hear me now?
Yeah, but there is a sort of noise. I don't know if it's, I think also
okay.
Yeah, but if there is nothing to do about it, it's okay. We can understand you.
All right, where was I? I mean, well, if Lorena or Krista have any other thoughts about this, please jump in. But I think we did consider defining our exposure definitions, maybe not so much just by any use, but thinking about these initiators versus not. But I think in this case, sometimes in pregnancy, when we're just interested in the exposure at all during a certain period, maybe the target trial becomes not quite as important, perhaps. I mean, you end up answering a slightly different question. So, Krista, feel free to jump in here.
Sure. Yeah, I've been giving it a lot of thought, and I really think, I mean, the way I see it at this point is like the target trial, it almost seems like to be this continuing of choices, right? So I think even when we do our observational study, which is not explicitly sort of conceptualized as a target trial, I think we still try and make all of these decisions to sort of try and really mimic that randomized experience that we can't do. And I think a lot of the deviations from the true conceptualization of the trial to what our observational study ends up being is sort of imposed by data limitations, right? For example, yes, ideally everybody in your cohort will have the diagnosis of interest at the start, which is what you would do with a trial. But we know, given the limitations of administrative data, sometimes we have much better capture when we allow some of these diagnoses to be recorded at some later point during pregnancy, and therefore we'll still allow them in the cohort, even though the diagnosis, for example, the indication was only documented later. So I feel like as long as we keep the target trial framework in mind and sort of think through all of our decisions with the framework in mind, but still allow some deviation that is sort of imposed by the limitations of the data, I think that already it will be helpful and sort of, and I think that's often what we try to do when we think through our main analysis and our sensitivity analyses. I mean, it's different from the nested trials that they were also talking about yesterday. In terms of pure implementation, thinking of the examples that I presented today, where it's really this multinational collaboration and there's some restrictions in terms of what can be shared and so forth. I mean, there's even an additional practical hurdle, I think, with the implementation of some. But sort of the main message that I took away from the workshop yesterday was to really try and keep that framework in mind. And with every design decision, with every analytic decision, be conscious of what it is you're sort of trying to mimic in terms of the target trial.
Yeah, thank you. Yes, do you want to add something, Laureen, or are you okay with the answers?
I think I'm okay. No, I think like Krista basically captured everything that I had in mind. So thank you, Krista.
Yeah, then I don't see any question. I have another one to Elizabeth. I was wondering a bit that now there's been some studies looking at ADHD and autism in children after antidepressants exposure in pregnancy. But I think there was also couple of studies looking more at psychiatric disorder in the child, like more depression and anxiety. So I was a bit, are you going to look at these other outcome measures, more behavioral measure, how the child is doing later on in terms of mental health?
Yeah, we don't currently have plans to. I mean, our behavioral disorders definition may capture some elements of that in the current study, but no, I mean, we don't currently have plans to look at specific diagnosis of depression or anything like that in the child. I do think the behaviorals definition maybe does capture things like anxiety and such. Lorraine is nodding yes, I think so. So we're capturing that a bit here, but maybe not explicitly as, you know, these teasing out the individual diagnoses in the children.
Yeah, thank you. Deborah, do you have any question? Yeah, please.
Oh, lovely. Thank you. I've got a question to Krista, actually. Love the table. I'm going to use that because certainly we're starting to see regulators asking for these multiple comparisons. And, you know, it clearly there is some use, but there's also a lot of challenges in the interpretation of the information when you make so many comparisons. What are your thoughts about, you know, the usefulness of doing so many and with so many outcomes? It kind of, you start, you know, you can't see the wood for the trees in the end, can you?
Yeah, no, it is definitely challenging. And we've spent like hours and hours discussing that within our research group. So when we were doing this study and trying to decide with all of this information, how do you now present that? And not just present, but also interpret in a way that is meaningful. But while I agree it is super challenging, I don't think there is an alternative, right? Because the simple way would say, well, we have one exposure and one outcome, but the interpretation of that specific relative risk, in essence, I mean, would still benefit from the other information, right? So I think the challenges we have when interpreting a relative risk, when we have an uncommon outcome, when we have an uncommon exposure, is really unrelated to how many exposure outcomes associations that we're evaluating simultaneously. I think it just makes it more clear when you're doing so many, because then if you're looking at like the table with 198 comparisons, like, yeah, you see some relative risks a little bit below the null, some a little bit above the null. And like we've spent a lot of time in our team discussing, does our interpretation differ if we're doing a study where we're just looking at one or a handful of exposure outcomes associations versus when you're looking at so many, as is the case in this study? And I think it does, right? Because you are influenced by either just being able to focus on a few or having so many to look at simultaneously. But I think that the core problem remains the same in the context of rather sparse information, despite these very large data sources. How do you now interpret it? And especially, I think, sort of that lower half where you see these high relative risks lighting up. If we just looked at a few of those, you would say, oh, look at how large the relative risks are, but it sort of helps to put it in the context of like, yeah, that's often just one or very few events, and see it sort of lights up across the spectrum. So I think it's super challenging. I'm not sure it's truly specific to the number of associations you're simultaneously evaluating. I think it just makes the problem more clear and more evident.
I mean, I was thinking of the analogy when you do in signal detection, where you're doing multiple, drug event combinations, and there one starts introducing, the caveats to the analysis. So you start restricting, or you add in correction factors.
Right. And so, go ahead. No, and I agree with the signal detection, like it's often still the driving factor to look at it is still often p-value driven, right? And we sort of try to sort of stay away from that in creating the summary table and say, like, let's not focus on statistical significance per se. Let's keep to our core principles that we want to estimate the magnitude of the association, and we want to have information on the precision. And that's why we sort of decided, well, why don't we look at the upper limit of the 95% confidence interval? Because that sort of allows us to say, well, we can exclude risks of this magnitude versus not.
Yeah.
But that's why I did make that comment. I mean, we did do the analysis and tested, like, okay, if we adjust for the multiple testing, do any of these associations, are they statistically significant? Which is sort of going a little bit to the signal detection type of approach.
Yeah.
We didn't, at this point, want to make that a core piece of information displayed in the table, although I must admit, in all honesty, an earlier version did have it, but then we decided, no, that's sort of moving away from what we say the focus should be. But yeah, it has a little bit in common with sort of signal detection. I mean, the big difference being that each of the associations we looked at, I mean, the study was designed very specifically for that exposure outcome association. So confounding control, the selection of confounders and so forth, was targeted to the problem we were looking at. Whereas I think sometimes in signal detection, if you're sort of looking across a broad range of potential outcomes, in that first screening, the confounding adjustment will be a little bit less targeted towards the studied associations.
Yeah. Thank you.
I think Marta, did you raise your hand?
I know I just had a question for Krista, but I think I got the answer. Wondering how to present this in a way that is meaningful, but also honest. It's very difficult because it's really important information, that sort of this really rare outcome that you can get really strong associations. But you gave an excellent answer, so thank you.
Thank you. Yeah, and as I said, like, this is just like a proposal that our group came up with. So very open to feedback and comments and other suggestions, but we sort of felt like if we have the point estimate, if we have the upper limit of the confidence interval, then we sort of have the important pieces of information. Ideally, the total number of events will also be helpful, but there we sort of restricted with these disclosure restrictions that I was referring to.
Okay.
Yeah, I don't see any question in the chat or in the Q&A. So
somebody raised a hand. Sarah, when?
What is it?
Yes.
Yes. Sarah, when can you?
Are you ready to end the session?
No, there is a participant that has raised his hand. I think he wants to, to talk, but I know it's muted.
Oh, okay. Can you hear me now?
Yes.
Yeah.
Oh, okay. Yeah. I do have a question for Krista. And it's wonderful to say so many studies that found out that there's no any association between antidepressant use or antipsychotic drugs use during pregnancy. I think it's a good message for physicians and also for pharma companies. My question is, even the relative risks, the point estimate are pretty small. And also, as Krista mentioned, in that lower parts of your big table, the real outcomes occurred in the exposure group could cause large point estimates. But if we're considering those real outcomes that could occur in a large population in like 1 over 1,000 or 1 over 10,000 general population, but in the exposure group, if we have 2 or 3 events occurred in 100 exposed people, so, you know, considering that large ratio, so I would still think that could not be by chance, even, you know, it's real events. So because my group had the same situation, and we have done some analysis for the opioid use, and we checked the adverse actually pregnancy complications and also neonatal adverse outcomes. And we did have this kind of like situation. We have a rare events occurred, rare events occurred in the exposed group, but it has a large ratio. And of course, we have large confidence interval, but it's significant. So, but I mean, I don't know if we should conclude that there's no causal effects between the exposure and outcome. So that's, you know, I like to discuss with you guys, and I mean, I think it's a good question, and I mean, honestly, I don't know how to really you know, interpret those results. Thank you.
Yeah, no, I think that's a really good point, and it's like the problem is that we're trying to interpret data in the context of very limited information, right? So the point I was trying to make is like, whenever you have a relatively small exposed group, the first event which will happen will by definition result in that very large relative risk, right? Even if there's no association whatsoever, because you have a small denominator, at some point, even if the event occurs totally by chance, it's really going to increase that relative risk by a lot. And in some people, like in the signal detection world, actually don't pay attention as long as you have just one exposed event. I think there's been examples in the past also from the case control surveillance approach, where actually they start paying attention when there's at least 3 exposed events. And whether it's 1, 2, or 3, I think it's all trying to get to that same issue, right? So when do you feel there is enough information to interpret whatever signal that you're seeing as a potential signal that there is an increased risk? And the main message I wanted to convey was not just ignore it, but I mean, pay close attention to it, but like be mindful of the fact that that first event by definition will bump up that relative risk by a lot. And I think we've also seen that in the context of the prospective exposure registries, like by definition, the first exposed event will have that effect. And it's important to sort of then monitor and see, like, if you start seeing a second event in a small group, then you start becoming more concerned. But in the lower part of our table, these large relative risks that were significant, they were all based on just one event.
Okay, I think that's it, isn't it, Angela? No more questions. So I'd like to take the opportunity to thank all our speakers for presenting this evening, this afternoon. I hope you enjoy the rest of the conference, and thank you to the attendees for joining this call. So again, thank you very much.
Thank you. Take care.
Bye.
Bye.